So what's abnormal on this chest radiograph?
Pulmonary.
Would you say prominent, or would you use some stronger terminology here?
Dilated
Yeah, so what's dilated?
pulmonary artery.
So this guy here is what?
Pulmonary artery.
Yeah, it's the main pulmonary artery, and that's pretty massively dilated. This guy over here is the right pulmonary artery, so those guys are pretty big. Here on the lateral view, this round lucency, what is that?
Left main bronchus.
That's the left upper lobe bronchus or left main bronchus, depending on the patient's anatomy. Here's the left pulmonary artery going up and over the left upper lobe bronchus, so you can see that that's dilated. And then this is superimposition of the main and the right pulmonary artery, so that's also dilated there. Okay. So we have dilatation centrally, dilatation of the central pulmonary artery, so therefore we're thinking that this patient has pulmonary artery hypertension. Now, what's your approach to pulmonary artery hypertension? So if we see it on the chest radiograph, what's our approach? What could this be caused by? Do we have a general approach to how do we approach pulmonary hypertension from the point of view of the chest radiograph?
Vascularity.
Like, you mean how to go through it, or if it's pre-capillary?
Well, so that's one approach, right? So pre-capillary, capillary, post-capillary, the approach to how do we approach the differential for pulmonary artery hypertension. But in medicine now, there's the data point classification, which we'll talk about, but the definition, sustained elevation of pulmonary artery pressure, mean pressure greater than 20 millimeters of mercury. The technical definition, when you have pulmonary arterial hypertension, is elevated precapillary pulmonary resistance with normal pulmonary venous wedge pressure. So that's data point group 1. But generally, we're talking about elevated pulmonary artery pressure. So when we're talking about, in medicine, they use the data point classification of pulmonary hypertension, and I think this is something that you will need to know for the core exam. So group 1 is if we have idiopathic pulmonary hypertension, if it's from congenital heart disease, portal pulmonary hypertension, HIV drugs. So this is a abnormality of the pulmonary arteries themselves. 1' is pulmonary veno-occlusive disease. Group 2 is if there is left heart disease that is resulting in elevated pulmonary venous pressure, which then secondarily elevates the pulmonary arterial pressure. So with group 2, there's pulmonary venous hypertension. So the two most common diseases in that category would be chronic left ventricular failure, rheumatic heart disease, or mitral stenosis. Group 3 is pulmonary hypertension associated with hypoxemia. So this is patients with lung disease. The most common cause of pulmonary hypertension in the United States is COPD. So lung disease could be COPD, interstitial lung disease, sleep apnea. Group 4, pulmonary hypertension from thromboembolic disease, so chronic thromboembolic disease, parasites like schistosomiasis, worldwide sickle cell disease could also do that. And then group 5 is unclear or multifactorial, pulmonary hypertension from disorders that are directly affecting the pulmonary vasculature, sarcoid, LAM, LCH. So this classification is related to also the treatment, because the different categories would determine, what treatment can be offered to the patient. So that's the data point classification of pulmonary hypertension. The problem with pulmonary hypertension is once the pressure starts to go up, then you get intimal cell proliferation, medial smooth muscle hypertrophy in the walls of the pulmonary vasculature. So that intimal proliferation then and the hypertrophy of the muscles means it starts to elevate the pulmonary vascular resistance, and that further increases the pulmonary hypertension. And then you get into this vicious cycle where it can progressively get worse. So for radiology, I think an easier approach as far as the way we think of it is to think of it as precapillary, capillary, post-capillary causes. So what do I mean by that? So the first category is things that increase flow through the pulmonary vessels. So this is the category where you have left to right shunts. The most common left to right shunts, ASD, VSD, PDA. So things that increase flow through the pulmonary vessels, left to right shunts. That would be the first thing. Second category, decreased cross-sectional area of pulmonary vessels. So things that are either destroying the pulmonary vessels or decreasing the number of vessels that you have available. So big thing in this category is chronic thromboembolic disease. Worldwide schistosomiasis can obstruct pulmonary vessels. That can be a common cause of pulmonary hypertension in undeveloped countries. And then here you also have primary pulmonary hypertension, portal pulmonary hypertension. So these are abnormalities of the vessels themselves. Then in this category also diseases that destroy pulmonary capillaries and pulmonary vessels like emphysema and lung diseases. Right? So all of these can result in pulmonary hypertension. And then the last category is things that cause pulmonary venous hypertension. So these are post-capillary causes. Chronic left ventricular failure, mitral stenosis, these are the most common diseases in this category. Then there are others that are less common, but these are the most common. So in these cases, you'll have pulmonary venous hypertension, and then that secondarily results in pulmonary artery hypertension. What's the imaging evaluation for pulmonary hypertension? Well, echocardiography is the first thing you do if we suspect that there's pulmonary hypertension. So on chest radiograph or on CT, if we suspect pulmonary hypertension, we recommend echo to confirm that there's pulmonary hypertension. How do they determine that there's pulmonary hypertension on echocardiography?
Looking for signs of elevation of pressure.
So what is that? When you look at your echo reports, there is an area there where they give you an estimate of the pulmonary artery pressure. How do they do that? How do they estimate the pulmonary artery pressure?
Tricuspid.
What? Somebody said.
Why it says velocity of the tricuspid.
Yeah, so by the velocity of the tricuspid regurgitation. So they'll look at the tricuspid regurgitation jet and they measure the peak velocity. What does that tell you? What does the peak velocity of the tricuspid regurg tell you?
The degree of afterwards?
No. Remember, whenever you're looking for stenosis with Doppler, you look at the peak velocity, right? What information does the peak velocity give you?
Pressure difference?
Pressure gradient, right? The peak velocity of the tricuspid regurg gives you an estimate of the pressure gradient between the right atrium and the right ventricle. The pressures in the right atrium are usually
It's supposed to be lower.
quite low, very low. So it's almost completely a measure of the pressure in the right ventricle. So that peak velocity of the tricuspid regurgitation allows them to estimate the pressures in the right ventricle. And so if there's no evidence of obstruction of the right ventricular outflow, then that's the pressure in the pulmonary artery. So that's how with echocardiography, when we recommend echocardiography to confirm that there's pulmonary hypertension, that's how they do it. Okay? So the workup, we start with echocardiography. The first test that they will get is, usually we send them to a nuclear medicine study, especially if we're looking for a chronic thromboembolic disease as a cause of pulmonary hypertension. So if the nuclear medicine study, perfusion study is normal, then they don't have chronic thromboembolic disease. And then to better evaluate that, if we're worried about that, then we get CT. And with CT, we can evaluate the pulmonary arteries and look at the pulmonary vessels for thromboembolic disease. Also, you're looking at the lungs to look for any evidence of lung disease that can be a cause of pulmonary hypertension. Then they might go to right heart catheterization to confirm the diagnosis of pulmonary artery hypertension. They'll take pressure measurements and also response to vasodilators to see what the pulmonary vascular resistance is and to see if that responds to vasodilators. Because if it's especially, for idiopathic causes of idiopathic pulmonary hypertension, that can respond to vasodilators. For functional evaluation of the right ventricle itself, MR is the best non-invasive way to actually evaluate the right ventricular function with MR. So you can look at the hypertrophy, you can look for hypertrophy of the right ventricle, you can look at the right ventricular size, you can actually evaluate the function of the right ventricle with MR. So what are the findings on chest radiograph of pulmonary hypertension? Well, the enlarged central pulmonary arteries, you might have right ventricular enlargement, talked about the enlargement of the pulmonary arteries. Pulmonary artery calcification, the only differential pretty much for pulmonary artery calcification is pulmonary hypertension, longstanding pulmonary hypertension. If the pulmonary hypertension is caused by pulmonary venous hypertension, then there might be signs of the underlying disease. There's left atrial enlargement from mitral stenosis, left ventricular failure, or evidence of the pulmonary venous hypertension itself, with vascular redistribution, interstitial edema, curly V lines, etc. So if there is no lung disease on the chest radiograph, what are the things to think about? Underlying congenital lesion resulting in Eisenmenger syndrome, chronic thromboembolic disease, idiopathic pulmonary hypertension. Remember that idiopathic or primary pulmonary hypertension is a diagnosis of exclusion. If there is lung disease, well, what's the lung disease? Emphysema, COPD, is the most common cause of pulmonary hypertension in the United States. If there's fibrotic lung disease, then that's probably obvious on the chest radiograph, and talk about the differential of what it could be. If there's pulmonary venous hypertension, if there's evidence of pulmonary venous hypertension on the chest radiograph, are there signs of mitral stenosis, chronic left ventricular failure? These other things are much more difficult to make the diagnosis with chest X-ray, but these two are the more common things that you might see. Okay? So that's the approach from the chest radiographic point of view. What do we see on this chest radiograph? Well, the topic is,
Pulmonary artery hypertension.
and what do we see? Yeah, I mean, there's an enlargement of the central pulmonary artery, so this patient has pulmonary hypertension. But is there something else? Is there some unusual finding here?
Pulmonary artery calcification.
Yeah, if we look very carefully, you see this, there's calcification of the aorta, but right here is calcification of the pulmonary artery. So calcification of the pulmonary artery is an indication of long-standing pulmonary hypertension. And here you can see the calcification of the pulmonary arteries here within the wall of the vessel. This patient's underlying disease is emphysema, central lobular emphysema is the cause of their pulmonary hypertension. The findings on CT of pulmonary hypertension, right? So what are the findings on CT that would lead us to suggest we think this patient has pulmonary hypertension?
Dilated pulmonary trunk.
Yeah, the dilated pulmonary trunk. So where do you look at it?
Level of the tricuspid.
No, not the level of the tricuspid valve. We're nowhere near the tricuspid valve here. Right? What you see here, this level right here. So where you see the main pulmonary artery in the bifurcation, and where you also see the ascending aorta. So the diameter of the ascending aorta and the diameter of the pulmonary artery, the main pulmonary artery, should be the same. Why? Why are they the same? They have the same amount of blood flow going through them. They should have the same amount of blood flow going through them, right? So they should be the same. About 3 centimeters. So the diameter of the aorta is about 3 centimeters. The normal diameter of the main pulmonary artery is about 3 centimeters. So a nice estimate. You look right at the aorta and look at the pulmonary artery alongside of it. The pulmonary artery looks bigger than the aorta, and we start thinking about pulmonary hypertension. But if it's like to use that 3 centimeter cutoff, if it's greater than 3 centimeters, start thinking about it. And the more it's greater than 3 centimeters, then the more likely it is. When you look at the heart itself in a patient with pulmonary hypertension, artery hypertension, what do we see about the heart itself on CT?
Right atrial or right ventricular changes.
Yes, so there's right ventricular and right atrial enlargement, and there's right ventricular hypertrophy. Right? So you see right ventricular hypertrophy, so that tells us that this is chronic pulmonary artery hypertension, so the right ventricle is dilated. Why is the right atrium dilated?
Eventually it starts to get some of those pressures.
Well, why does it get exposed to those pressures?
Regurg?
Tricuspid regurg, yeah. The tricuspid valve does not handle elevations in right ventricular pressure very well. So it's common for these patients to develop tricuspid regurgitation. Right? So dilated right heart, right ventricular hypertrophy, right atrium. This last image, what are the arrows pointing out to you? So what is this illustrating, this last image?
Dilated pulmonary veins.
Not dilated pulmonary veins, no. These are dilated central pulmonary arteries. But why are these arrows here?
Central lobular nodules.
Yeah, the central predominance. So What it's showing is that the central pulmonary arteries are dilated out of proportion to the diameter of the vessels more distally. And the term for this is, there's a term,
Pruning.
pruning, right, this is pruning. So if the central pulmonary arteries are larger than the vessels in the periphery, that is pruning. That's a sign of pulmonary artery hypertension. If you have dilated central pulmonary arteries and the vessels in the periphery are also dilated, right, what might that suggest?
Chronic
No. Increased flow, left to right shunt. Right, so that's shunt vascularity. If you have dilated central pulmonary arteries, but vessels, the pulmonary arteries are dilated to the periphery, that tends to be shunt vascularity, left to right shunts. Okay? The MR findings of right ventricular pressure overload. Well, dilated right ventricle, dilated right atrium, right ventricular hypertrophy, right? The interventricular septum kind of shifted towards the left ventricle. The paradoxical motion of the interventricular septum also with elevated right ventricular pressure. What do we see on myocardial delayed enhancement when you have right ventricular pressure overload? It's illustrated
Hinge point
here.
enhancer.
Yeah, so there's enhancement here at the hinge points. So here at the insertion of the right ventricle on the interventricular septum, you have enhancement at the hinge points. And it's thought that this is due to abnormal stresses in this region that results in fibrosis, and that causes this degree of enhancement. There's another disease that's also associated with myocardial delayed enhancement at the hinge points. What is that disease? Yeah, Holcomb, hypertrophic cardiomyopathy. But of course, that's going to look much different than this, right? So you're going to have hypertrophy, you're not going to have dilated right ventricle, so that looks different. But that also can give you delayed enhancement like this at the hinge points. Okay? The D-shaped right ventricle, when you have tremendous elevation and the pressures here, where the pressures can actually be greater than the systemic pressures, then the interventricular septum can be shifted completely towards the left ventricle. You get this D-shaped right ventricle. Notice the extensive right ventricular hypertrophy in this case. So all of these are signs of right ventricular pressure overload, okay, on these short axis view. Okay, so this is not an eye test. What do we see here?
Cardiomegaly, big pulmonary arteries.
Yeah, big or massive?
Massive.
Yeah, there's massive dilatation, aneurysmal, right? Massive dilatation of the central pulmonary arteries. What is the differential diagnosis for aneurysmal dilatation of the central pulmonary arteries?
Vasculitis.
Well, what vasculitis, since you bring up vasculitis, what's the vasculitis that affects the pulmonary arteries?
Takayasu.
Takayasu's is the most common, right? But there's another one that has a propensity for the pulmonary arteries only, as opposed to the aorta. Eustace-Vance syndrome. Eustace-Vance syndrome. Right, for pulmonary. That's really rare stuff, though. But somebody brought up left to right shunt, right? But go beyond that and you call it what? Eisenmenger's, right? So Eisenmenger's physiology can also give you this kind of aneurysm. So if you have an adult with massively dilated central pulmonary arteries, one of the first things to think about is Eisenmenger's. Is this the patient who has Eisenmenger's, right? So that's another cause. Severe pulmonary regurgitation can also result in aneurysmal dilatation of the central pulmonary arteries. So here's the head CT that goes along with this patient. Listen. So how do we put this together? What are we thinking about here?
ASD.
So we think what?
PFO, ASD, some defect.
Well, wait. PFO and ASD are two different things.
Right.
Which one are you going to go with?
So it's paradoxical emboli, probably P.
There's a chest X-ray here. Do you see that with a PFO?
Okay, so
So you're going to go with what?
ASD.
Yeah. So ASD, which then resulted in Eisenmenger's paradoxical embolism. Right. So, of course, PFO can give you paroxysmal, but that's not going to give you this appearance of the central pulmonary arteries. Right? And what do we see on the CT? Big pulmonary artery, we're not surprised. Big right ventricle hypertrophy, big right atrium. And the underlying disorder is?
Big V, big ASD.
Yeah, big atrial septal defect that resulted in Eisenmenger in this patient. The most common of the left to right shunts to present in the adult is ASD, atrial septal defect is the most common of the left to right shunts to present in the adult. So Eisenmenger syndrome is when you have severe pulmonary artery hypertension that results in conversion of the left to right to right to left, or really bidirectional, and results in cyanosis because now you have what started out as a left to right shunt, now you have right to left shunt. So it can occur usually to a large VSD, but it can also occur from ASD or PDA and bidirectional shunts with more extensive congenital heart disease. So that's Eisenmenger. So if we have an adult with massively dilated central pulmonary arteries, make sure that we consider Eisenmengers. So enlarged central pulmonary arteries, right atrium, right ventricle will also be enlarged. There's another case where this was from an atrial septal defect. When you have tremendous elevation of pressures in the pulmonary circulation, you can also develop atherosclerotic disease. So you can see the calcification in the wall of the pulmonary artery, just like in the aorta. This can also happen in the pulmonary arterial circulation. Okay. So what do we see here in this case? What's going on here?
Chronic PE.
So what makes you say it's chronic thromboembolic disease? So the filling defect is eccentric. It's along the wall. And then here also on the cross-sectional view, you can see that the filling defect is eccentric along the wall of the vessel. So this is chronic thromboembolic disease. So what's happening here is that the clots are being organized now into the wall of the vessel. And just like it's affecting these large vessels here, it's also affecting a lot of small vessels more peripherally that you can't see. And that's resulting in pulmonary hypertension. Notice the big right ventricular hypertrophy. So this patient has pulmonary hypertension from chronic thromboembolic disease. So in 5% of cases, the lysis fails and it can result in chronic thromboembolic disease, which can result in pulmonary hypertension. So here's a big infarct, and there's your acute PE, and in some cases that can progress to chronic thromboembolic disease. So for chronic thromboembolic disease, we look for signs of organized thrombus, so the filling defect will be in the periphery of the vessel. You can also see webs. So webs within the vessel, these are signs of incomplete recanalization. So webs within the pulmonary vasculature is also a sign of chronic PE, chronic thromboembolic disease. What's illustrated here?
Mosaic attenuation.
You can be more specific than that. Mosaic what? Mosaic perfusion, right? And in this case, it's secondary to
PE.
chronic PE. You can see, again, the filling defect along the pulmonary artery wall in the periphery, here in the left interlobar pulmonary artery. What's the most common cause of mosaic perfusion? Air trapping is the most common cause of mosaic perfusion. What's the difference between mosaic attenuation and mosaic perfusion? Well, how they look, yeah, but what's the difference in how they look?
What is the genealogist, like how bright it is in the vasculature versus how dark the parenchyma
So it's
is?
it's not how dark the parenchyma is, but what the vasculature looks like. Right? So mosaic attenuation is a non-specific term. The term mosaic attenuation means that you have areas of increased opacity mixed with areas of decreased opacity, right? So if we had ground glass consolidations from pneumocystis pneumonia, these are the areas, let's pretend, of ground glass consolidation, that's also mosaic attenuation. But in that case, the ground glass areas are the abnormal areas. When you have mosaic perfusion, it's the lucent areas that are the abnormal areas. And it's loosened from decreased blood flow because you have, and you can see, we call it mosaic perfusion, we see that the vessels are smaller in these areas of decreased attenuation. So when we see that, then we can say it's mosaic perfusion. So the two major causes of that, the most common cause, far and away, is air trapping, right? And the air trapping also makes it lower in attenuation because there's air trapping, and also because the blood flow is shunted away from those areas of air trapping, the vessels will look smaller. So when the vessels look smaller in these areas of decreased attenuation, we call it mosaic perfusion. But the second cause of mosaic perfusion is vascular disease, and the most common of those vascular diseases is chronic thromboembolic disease. And then to make that diagnosis, you look at the vessels. Are the central pulmonary arteries dilated? Or is there signs of chronic PE? Another finding is that when you just look at the lung windows, when you have air trapping tends to break down into pulmonary lobules. You can see individual pulmonary lobules of air trapping. Whereas when you have mosaic perfusion for vascular disease, it's more diffuse, like you can see in this example. Okay? So this is chronic thromboembolic disease resulting in mosaic perfusion. Right? Same idea here. The central pulmonary arteries are dilated. These areas of lucency have decreased vascularity. So this is mosaic perfusion from vascular disease. The most common of those is chronic thromboembolic disease. Central pulmonary arteries are big, telling you this patient has pulmonary hypertension. So we just discussed all of that. We talked about how we differentiate this from air trapping. This patient has large chronic PE. You can see it. No mystery there, right? What else is abnormal? Nicely illustrated on the coronal image.
Wow.
Well, what are these guys?
Bronchial artery?
Yeah, these are dilated bronchial arteries. So dilated bronchial arteries can also be associated with chronic thromboembolic disease. So they dilate because they act kind of like collateral flow, right? But dilated bronchial arteries, this is also associated with chronic thromboembolic disease. So you might see that. So you can look for that. The parasite associated with pulmonary hypertension, schistosomiasis, right? Obstructing the pulmonary vessels. Okay? Idiopathic pulmonary hypertension is a diagnosis of exclusion. On the chest radiograph, it can look like any other cause of pulmonary hypertension, so you have to rule out everything else before you give the patient a diagnosis of idiopathic or primary pulmonary hypertension. Usually affects young females, progressive shortness of breath. There is some association with Raynaud's, but it is a diagnosis of exclusion, and dilated central pulmonary arteries kind of looks like all the other causes of pulmonary hypertension. So this patient also has massive enlargement there of the central pulmonary arteries. What is this patient's problem? It's emphysema, right? So you can see the increased lung volumes, the flattened diaphragms, retrosternal clear space. So this patient has pretty bad emphysema. Big central pulmonary arteries, and on the lung windows, you can see all of the emphysema. So this is the most common cause of COPD, is the most common cause of pulmonary hypertension in the United States. Big right ventricle, big right atrium, right ventricular hypertrophy, all of these things that you would expect to see. So here's a man with pulmonary hypertension, big pulmonary artery. Any thoughts about this case?
Obstructive sleep apnea.
Well, that's certainly a consideration. So you're thinking about that because you think the patient might be.
Because he has a gynecomastia.
Well, that's interesting, right? Why? This patient does have gynecomastia, right? So why does this patient have gynecomastia? In this hospital, when we see a man with gynecomastia,
Cirrhosis.
Oh.
cirrhosis, so how does that go along with this? Oh, now you stepped into it, didn't you? Is this hepatopulmonary syndrome or is this something else? What's the pulmonary vascular resistance with hepatopulmonary syndrome? Is it elevated or decreased? It's decreased. So what is the disease associated with cirrhosis that gives you pulmonary hypertension? What is that called?
Portal pulmonary.
Portal pulmonary hypertension. That's called portal pulmonary hypertension. Okay. So this patient does have cirrhosis, right? we do see this in this hospital quite a bit. 2 to 5% of patients with cirrhosis have portal pulmonary hypertension. And we have this hand-waving explanation, vasoactive substances not metabolized by the liver that bypass the liver via portosystemic shunts result in this abnormality of the pulmonary arteries causing pulmonary hypertension. So pulmonary hypertension associated with cirrhosis is called portal pulmonary hypertension. Okay? This patient is hypoxic. What can we say about this? That's a big spleen. What about the liver, by the way? What do you know about the liver? It's another patient with cirrhosis, right? Hmm? Does have varices, yeah. There are varices. Do you notice anything on the lung windows that's unusual? Well, the pulmonary vessels, you can follow them all the way to the periphery of the lung. Right? Usually we can't follow pulmonary vessels like that all the way to the periphery of the lung. If we see this in a cirrhotic patient who's hypoxic, what do we think about here? Well, here's a perfusion scan, MAA perfusion scan on this patient. What does it show?
Something.
Shows nothing?
Shunting.
Shunting? Well, how do you know there's shunting? What kind of shunting?
PE. With left direction.
Not left to right, no.
I'm sorry,
Right to left. But how do
right
you
to
know?
left.
How do you know there's right to left shunting?
What brain are you
There's
in?
uptake in the brain and the kidneys, okay? So when you're doing a perfusion scan, you diagnose PE by giving the patient PE. You inject MAA into the vein, and then the technician-labeled MAA gets trapped in the pulmonary capillaries, right? So you're giving the patient a PE to diagnose PE, and that's why the lungs show up on your perfusion scan. But if there's a right to left shunt, then those large particles are able to get across to the systemic circulation, and they show up in the systemic circulation in the brain or the kidneys. So that tells you that there's a right to left shunt. So a cirrhotic patient who's hypoxic with a right to left shunt, what do we call this? This is hepatopulmonary syndrome. So these patients develop small arteriovenous shunts in the periphery of the lungs, and that's why the vessels are dilated all the way to the periphery of the lungs. And that's where the right to left shunting occurs. It occurs here in the periphery of the lungs, and these patients can be hypoxic. Okay? So don't confuse this with portal pulmonary hypertension, right? These two are often confused for each other. Cirrhotic patients, but these patients have decreased pulmonary vascular persistence. These patients have hypoxia because of the right to left shunting. Okay, that's hepatopulmonary syndrome. This patient also has big pulmonary arteries. What's this patient's problem? By the way, what do we call this? Cephalization, right, there's cephalization here. Well, what chamber's enlarged? Left atrium, yeah, the left atrium is large. So a patient with an enlarged left atrium, cephalization and pulmonary hypertension, the underlying disease is mitral stenosis from rheumatic heart disease. So in 99% of cases, if we see a chest radiograph like this will be rheumatic heart disease and mitral stenosis. The other 1% will be what else can occur in the left atrium? Rare, but obstruct the mitral valve and lead to mitral stenosis. Left atrial myxoma, right, that's the differential. But that is a very small percent. So 99% of the time, this will be rheumatic heart disease and mitral stenosis. Okay? So, and indeed, we see the big left atrium here, thickened mitral valve leaflets. It's a patient with mitral stenosis from rheumatic heart disease. And we've covered this, so I won't need to go through this in any great detail. We covered that in the past. So now we get into some rare birds. This patient has pulmonary hypertension with normal pulmonary capillary wedge pressure, right? But there are signs of interstitial edema. There's interlobular septal thickening, right? You can see the main pulmonary artery is dilated, the right ventricle is dilated, hypertrophied, right atrium is dilated. This patient has pulmonary hypertension. But they have pulmonary hypertension with signs of interstitial edema. And we said in most cases that's because of left heart failure or rheumatic heart disease, but those things would elevate the pulmonary capillary wedge pressure. This patient has normal pulmonary capillary wedge pressure. And that's part of the criteria for making the diagnosis of this particular disease. What is this disease?
Veno-occlusive disease.
Pulmonary veno-occlusive disease, yeah. So pulmonary veno-occlusive disease can also give you signs of pulmonary venous hypertension, but the pulmonary capillary wedge pressure in those patients will be normal, will not be elevated. Right? So pulmonary venous occlusive disease, this is from fibrosis of small pulmonary veins, usually young patients. It can be associated with pregnancy, bone marrow transplant, chemotherapy, viral infection, autoimmune disease. So the small pulmonary veins become fibrosed, and that results in the signs of pulmonary venous hypertension there, signs of interstitial edema, that then backs up into the pulmonary artery circulation, so they develop pulmonary artery hypertension. So they develop what looks like pulmonary, they have signs of pulmonary venous hypertension and pulmonary artery hypertension, but it's not from diseases of the left heart. This is from disease affecting the pulmonary veins. Okay? So they can have big main pulmonary artery, but they have some increased interstitial lines from interlobular septal thickening. I mean, it looks like they might have interstitial edema. They can have areas of ground glass opacity. Right? So you can see the thickened interlobular septae here from interstitial edema in these cases. Pulmonary artery hypertension, but the left heart is normal, hence the pulmonary capillary wedge pressure is normal. This is pulmonary veno-occlusive disease. Okay? They can have pleural effusions, a little bit of enlarged lymph nodes can also occur, but look at all this interlobular septal thickening, looks like interstitial edema. And then this one, along the same lines, another rare bird, another patient with pulmonary hypertension, normal pulmonary capillary wedge pressure. The tip-off here is there are these central lobular ground glass opacities, which actually represent areas of hemorrhage. These central lobular ground glass opacities in a patient with pulmonary hypertension. What is this?
Vasculitis?
What is it called?
Granulomatosis?
No.
The other one.
This is pulmonary, it's not really a vasculitis, it's a pulmonary capillary hemangiomatosis. So this results from proliferation of thin-walled capillary channels. They can bleed, they develop petechiae, they can have hemoptysis. These are the ground glass opacities, central lobular ground glass opacities that we see on CT is from bleeding. They will also have normal pulmonary capillary wedge pressure, and they can also have pulmonary hypertension. So it can look very similar, and also, they can present very similar to pulmonary veno-occlusive disease, pulmonary capillary hemangiomatosis. So they will have evidence of pulmonary hypertension. They might also have reticular nodular opacities, ground glass attenuation nodules from bleeding within the lungs. Septal lines tend to be less than with pulmonary veno-occlusive disease, so more ground glass opacities from the bleeding. So here's an illustration of normal with pulmonary veno-occlusive disease. The pulmonary veins here are obstructed, right? And then that results in pulmonary artery hypertension. With pulmonary capillary hemangiomatosis, the small capillaries proliferate, and then that causes a relative obstruction there, and that results in pulmonary artery hypertension. Why is it important to suggest this diagnosis if you think this might be the case? Because usually patients with pulmonary hypertension can be treated, especially idiopathic pulmonary hypertension, can be treated with vasodilators. But these particular diseases are contraindications to vasodilators, and giving these patients vasodilators can result in fatal pulmonary edema. So you want to make sure that if you're thinking about this, that you mention this because they don't want to put these patients on vasodilators. So usually when the patient is being worked up for pulmonary hypertension, when they do the CAT, of course they're going to measure the pulmonary venous wedge pressure. Again, that is criteria for making the diagnosis of these diseases, a normal pulmonary capillary wedge pressure. Okay? What do we got here?
Big old clot.
Big clot. And then the second thing you have to notice is, there's right heart strain, right? So the right heart is dilated. So in addition, when you see big clots, you have to talk about the right heart. So usually this right heart strain is associated with massive central pulmonary embolism. So when we see big clots, we want to go and make sure we look at the right ventricle, because if there's signs of right ventricular dysfunction, that's usually what causes the mortality in these patients. About 30% of normal intensive patients with PE can have right ventricular dysfunction, and that can increase the rate of PE-related shock and mortality. So it's an important thing to notice in these cases. Low-risk PE, no hypotension, no right ventricular dysfunction. Submassive PE, right ventricular dysfunction, massive PE, hypotension associated with the right ventricular dysfunction. Okay, so we look at the right ventricular to left ventricular ratio. It should be 1:1, but if the right ventricle is more dilated, then there's right ventricular dysfunction, there is right heart strain, and of course you need to mention that in your report. The bigger it is, the worse the prognosis, right? So big PE here, right ventricle really dilated. This causes acute cor pulmonale. This causes acute right heart failure. That's the cause of death for PE, is acute right heart failure. Other signs of elevated right heart pressure, reflux of contrast into the inferior vena cava. Right, so these are all signs of elevated right heart pressure. And we see contrast refluxing into the IVC in these patients with large central pulmonary embolism. Right? The larger that ratio, the more the right ventricle dilates, the worse the prognosis. Right? Massive right ventricular dilatation, this patient did not survive. Okay? Be careful, because not all cases when the right ventricle is dilated is it from acute PE. In this case, there's some right ventricular hypertrophy, so this is from PA hypertension that this patient has a dilated right ventricle. We talked about all this, right? So not all causes of right ventricular dilatation are acute PE. Cor pulmonale is when disease of the right heart is caused by problem in the lung. So that results in right heart failure, systemic venous congestion. Acute cor pulmonale, acute PE causes acute cor pulmonale. Chronic cor pulmonale, the most common cause is COPD, but any lung disease can do that. And so what are the signs of right heart failure on chest x-ray? Dilated right chambers. You can see on the lateral view the right ventricle is dilated. Here the right atrium is also dilated, so right heart, dilatation of the right heart are signs of right heart failure on chest radiograph. See on CT the big right atrium and the right ventricle, big IVC, pulmonary veins, signs of elevated, the hepatic veins, signs of elevated right heart pressure. That's all of those are signs of elevated right heart pressure. The differential diagnosis for enlargement of the main pulmonary artery segment on chest radiograph. We've talked about pulmonary artery hypertension, but there are other things that you might also want to consider. So in this particular case, this patient has a dilated main pulmonary artery. Does this patient have pulmonary hypertension, or this patient has something else?
Something else.
What's the something else? And how do you know it's something else?
The pulmonary artery is still fine.
Well, the right pulmonary artery looks okay, right? The right pulmonary artery is not dilated. So when you see a normal right pulmonary artery with a dilated main pulmonary artery, what do we think? Pulmonary valvular stenosis. What's the pulmonary artery pressure in patients with pulmonary valvular stenosis?
Normal.
It's normal, right? They don't have pulmonary artery hypertension. So when you see this configuration, we think pulmonary valvular stenosis. You see the main pulmonary artery is dilated, the left pulmonary artery is dilated, the right pulmonary artery is normal. Here's your jet for pulmonary valvular stenosis and post-stenotic dilatation of the main and the left pulmonary artery. Okay? Pulmonary valvular stenosis, big left pulmonary artery, normal right. Pulmonary hypertension, in this case from ASD, right and left pulmonary arteries are dilated. So you don't want to mistake this for pulmonary hypertension. Okay? Partial absence of the pericardium, we discussed this. That can also cause a bulge in this region, but it's not the pulmonary artery that's bulging. Right? So here there's herniation of the left atrial appendage that's bulging out there. And then this other unusual thing, tetralogy of Fallot with absent pulmonary valve. These patients have severe pulmonary regurgitation, and that can also result in dilated central pulmonary arteries. Usually patients with tetralogy of Fallot have small pulmonary arteries, so this is the exception. So in this case, because of the pulmonary valvular regurgitation from absence of the pulmonic valve, these patients have dilated central pulmonary arteries, even though they have decreased pulmonary blood flow. Okay? So that's tetralogy of Fallot with absence of the pulmonic valve. Causes of right ventricular enlargement. So here's a patient with dilated right heart. We talked about pulmonary artery hypertension causing right heart enlargement. Do we think this patient has pulmonary hypertension as a cause of their right heart enlargement?
No.
Why not?
Look normal, pulmonary arteries look normal.
I haven't shown you the pulmonary arteries.
Well, the parts that you can see, as far as the
Well,
part
that's
of-
no good. You want to look at the central pulmonary arteries. But from what I'm showing you, how do you know this patient doesn't have pulmonary artery hypertension? Or at least chronic pulmonary hypertension? Well, what's the status of the right ventricular myocardium? It's not hypertrophied, right? So this patient doesn't have chronic pulmonary hypertension. Could this be acute core pulmonary from massive PE? Yes. Yes, it could be, right? I mean, that could give you a massively dilated right heart. That could do it. What else can cause right heart dilatation?
Ischemic changes.
Well, you're saying a coronary right heart infarct?
Yeah.
Okay. Anything else? What kind of left to right shunt would give you dilatation of right-sided chambers? Which one?
Left to right.
Which left to right shunt? Which left to right shunt gives you dilatation of the right atrium and the right ventricle?
ASD.
ASD. That would be an atrial septal defect, right? Is there a cardiomyopathy that can give you right heart enlargement? Well, we did cover it. ARVD, right? Arrhythmogenic right ventricular dysplasia, right? Most commonly, though, especially if it's in a young person, this is a young person in Newark that has a heart that looks like that. What should you be thinking about?
Chagas?
What?
Chagas?
No, not Chagas. Well, the problem with what valve might cause this? Yeah, endocarditis of the tricuspid valve, resulting in severe tricuspid regurg. So what's the story?
IV drug abuse.
IVDA with endocarditis of the tricuspid valve, causing tremendous tricuspid regurg, and then this is why you have the right heart dilatation, right? So we discussed the differential for right heart enlargement, right? So there it is there. I didn't talk about Epstein's. Could this be Epstein's, yes or no? You say no, why not?
Valves in the right place.
What is in the right place?
The
Specifically, what is in the right place? Which leaflet? Oh gosh. The septal leaflet of the tricuspid valve has a normal insertion. With Epstein's, that would be displaced towards the apex, right? So this is an Epstein's. But Epstein's could also give you a heart that looks like that, right? So that's your differential, the right heart enlargement. Here's a surprise, kid. I mean, look at what is this? What does that turn out to be? That turns out to be the right atrium. It's another case of severe tricuspid regurgitation resulting in massive right atrial enlargement. Okay? All right, that's it for today. Any questions?